Welcome to the Alphagenix Podcast, where we discuss all things men's health and testosterone. And I am delighted to welcome back Dr. Andrew Winge. Hi, Andrew. How are you doing?
Hi, Ed. I'm great. Thanks, Max. Thanks for having me back. It's always a pleasure to come on the Alphagenix Podcast. So I never say no.
Good man. Good man. Yeah. Well, you're becoming a regular, like I am on your channel.
I think so. I think so. I know. That's it's good.
Medical buddies from across the pond. That's what
That's right.
Called.
That's right.
Yeah.
That's right.
Yeah. So we were just chatting before. We've covered debunking myths about TRT, expectations on TRT, or misexpectations maybe, and who shouldn't go for TRT. So today, maybe we'll cover a little bit about side effects or common side effects, or even potentially common mismanagement of side effects as well. I think it's quite an important topic, isn't it?
Absolutely. Yeah, absolutely. Because obviously on the internet and when you go to forums, you get a little bit of a one-sided take on testosterone therapy. It's all sunshine and roses, and not everybody talks about the downside. And in fact, very few people talk about the people that start TRT and have intolerable side effects and end up quitting testosterone therapy. So we have to present people with all of the information and help them make a decision themselves based on their own individual needs. And we don't, you and I are not salesmen for testosterone. I always try to convey that to my patients. I am not trying to sell you on testosterone. In fact, many times I spend a lot of time trying to talk guys out of testosterone therapy, and I know you do as well. So we're both horrible salesmen. If we were depending on our testosterone sales, I think I'd have to find another career, but I do have another career as an emergency physician. So, but anyway, you don't, so you're better at that than I am. But you get my point. It's we want to be, especially as physicians, we want to. Our roles is as an educator, and we want to present all of the information to patients and then let them make the decision that's best for them. And you've got to talk about the upsides, but you also have to talk about the downsides.
100%. Yeah. I actually use that line to my patients often. I say, I'm a terrible salesman.
Terrible.
Because at the end of the day, you've just got to make an informed decision, really. So you've got to know the ins and outs. And there are a lot of positives to TRT, particularly if you've got rubbish testosterone levels. But there are things I suppose with side effects, you could say that there are common side effects, things that most guys will experience, at least to some degree, particularly early on in treatment. And then there's less common side effects that some might run into. Yeah.
Sure. Absolutely. Some of the most basic things, sometimes I'm actually surprised because I get a lot of referrals from other clinics. And, these are patients that they weren't formally referred, but, maybe they just haven't been happy with the care, or they maybe don't feel like they're getting the attention that they need. But I'm still surprised a little bit about the number of guys that come to me that they haven't really been fully counseled in terms of the very basic stuff, like the fact that testosterone replacement therapy will, for example, shut down your own natural production. It seems like something so basic, you would think everybody would know that. But I still run into guys who that hasn't been fully explained to them, that the HPTA axis is turned off essentially, or certainly like massively down-regulated. And that has implications potentially, obviously for fertility, it has major implications. But if there's ever an interruption in therapy or discontinuation of therapy, it can have implications down the road. And sometimes men are not counseled about that. It seems so basic, but it does get sometimes just forgotten, I think.
Oh, 100%. Yeah, I've had examples of that in the last couple of weeks. I've had people even reach out to me over social media, like Instagram messages or email messages from other countries, where they've said to me, "Oh, hi, Dr. Max. I've watched some of your content, and I was wondering if we could have a consultation because I'm under X clinic, and I wanted to go into the ins and outs of treatment." And it's kind of like, that's what your clinic should be doing.
Precisely. Exactly. On day one.
Yeah.
On day one.
Yeah.
I just received an email, actually. It's funny you say that, just this week, about from somebody in another country who asked, it was a question about Sustanon, and asked specifically, will this shut me down in terms of their axis? And the other question he had is, will this affect my fertility? And he had already started on therapy. So I'm like, wow, like that's you had the world's worst counseling session before you started on this. If you're reaching out to me, some random guy on the internet that you don't know, to help you answer those questions. So again, it seems so obvious, it seems so basic to us, and I think most providers they don't do this, but some still do, especially maybe in other parts of the world where this is not perhaps as widespread or as common as it is, or it's becoming in the US and the UK.
So 100%.
Big problem. Big problem.
Absolutely. And I've seen people from your neck of the ponds. I've seen them even Australia, all over the place who've had these issues. So I think it is a bit of a worldwide thing. Where do you want to start in terms of the side effect discussion? I split things into, I often do this with symptoms of low testosterone, sort of psychological, physical, sexual. I don't know if you want to go down that route with
that's
this.
That's a great way to do it, because otherwise, we need some sort of organized framework. Otherwise we'll be all over the map. So so why don't you start off with that? We can maybe start off with the psychological.
Yeah. And I suppose with the psychological side of things, there's temporary things that are fairly common for some guys when they start treatment. And then there are other ones that might crop up during their treatment. I mean, certainly from a psychological perspective, one thing that I'll often mention to guys is, let's say you're starting on injectable cypionate. In that first sort of few weeks, rather than seeing a steady improvement in mood, which you might hope for, and maybe a reduction in anxiety, if that's part of your low testosterone picture, you might get some mood variability, mood fluctuations. You might get a little bit irritability. And so things aren't always a smooth progression in a linear process positively.
I think so too. It's not terribly common, but there can be obviously some fluctuations in mood. Presumably that's a result of fluctuating neurosteroid levels and neurotransmitter levels, and again, there's also people come with all sorts of underlying pathology and underlying psychological issues, personality disorders, those sorts of things, and that can be a little bit unpredictable, particularly in a man who's been low for a very, very long time. And then all of a sudden, especially if perhaps your dose is too high, or there's if you've been profoundly hypogonadal for a very, very long time, like a decade, and then all of a sudden within the span of 3 weeks, you're not only just eugonadal, but you're in the top 5% of the reference range, if not past that. It's obviously not inconceivable that you're going to have issues there. Yeah, for sure. One of the things I do see, and I always talk to men about this, and I think we've touched on this on other podcasts, is the spouse will sometimes make a complaint that he's become aggressive, or that he's, I don't know, that he's become more irritable, grumpy, etc. And it's been my experience, certainly sometimes that is true, but it's been my experience more often than not that what's really happening is that this man is becoming more assertive under the influence of testosterone, and he's becoming less tolerant of being sort of, for lack of a better term, being walked all over by his spouse. So oftentimes it's a dominant spouse who is perhaps accustomed to bossing her husband around and having him sort of meekly say, yes, dear, yes, dear, yes, dear. That man might be a little bit more likely to perhaps stick up for himself a little bit, or be a little bit less intolerant of bad treatment or poor treatment. And that's interpreted as he's aggressive. It's like, nah, he's just not putting up with your, what anymore. And asserting himself in a masculine fashion. So I have seen that quite a few times, and it can be a point of contention sometimes in a relationship. So.
Yeah, I mean, my wife doesn't like you for saying that, because often if we have a little...
Sorry, Katie, I'm sorry.
Yeah, I just say to her, Andrew told me this would happen. It's because I'm standing up for myself. It's probably right. more like it's probably more likely that I'm just being, a bit of an idiot. But hey ho, it's a good excuse.
I mean, that's always in the differential too, of course.
Yeah.
Of course. Yeah, but
But I think you pointed out something useful as well. There is the fact that particularly I don't know if you find this well. I tend to find that irritability or that mood variability can be more apparent in guys who've been potentially low T for a long time, or they, and obviously what we mentioned as well, you can't tease out always underlying psychological issues or what has been low testosterone, because obviously the two can exist simultaneously. You can have anxiety and depression, you can have a psychiatric issue as well as low testosterone. It doesn't have to be all driven by low testosterone, and that often takes time to tease out as well, because like we said before about testosterone treatment, is it doesn't work overnight. And you kind of, if someone presents with low testosterone and they've got anxiety, they've got depression, or they've got, various sort of mood issues, then I suppose the hope is that the testosterone cures that over time, or at least helps significantly. But it may be that the two problems have existed independently of each other. Yeah,
precisely. And it's entirely possible that, again, if you're a sociopath, and with hypogonadism, and we flood your system with testosterone, that you could become more of a sociopath, and start exhibiting negative behaviors. I personally haven't seen that, but you hear anecdotal stories and things like that. Thankfully, these things are rare. I think most of us, would agree that we have a long history of seeing patients improve in terms of mood, and generally the effects tend to be positive. But every now and then there's outliers, so it's worth mentioning to patients, I think.
Yeah, absolutely. I mean, in general, what we tend to see is a gradual improvement in mood,
Absolutely.
a gradual reduction in anxiety, and certainly a big one that we've spoken about, a common one, is an improvement in cognition and brain fog. Those are the big ones, hormonally speaking. Yeah, no
question about it. And that was the by far for me the biggest thing that occurred within the shortest period of time. Again, I fully admit it may have been a placebo effect, but it really did feel like within the first week, perhaps 10 days, that fog cleared and my mental clarity was back to what it used to be, really like in my mid to late 20s. And that was within a week or two of starting therapy. So that is a real phenomenon, and I hear that a lot.
Yeah. And one other thing that may be touched upon in the psychological area is maybe later down the line or even early on, and I think you touched upon it there as well, is if your dose is a little bit too high or even much too high, sometimes you will find that guys report that they feel a little bit restless, a little bit maybe just edgy, maybe the quality of sleep deteriorates. So that can be an indication sometimes that actually we're running a little bit high for you personally, and everyone's a little bit different where that ceiling might be. Some guys seem to tolerate higher levels than others, and there's various factors there. It might be the fact that the guy can tolerate better levels based on his genetics, how lean he is probably quite significant, how active he is, how well he's sleeping. There's so many factors that go into your tolerance potentially, but certainly one thing worth mentioning to guys out there is that sometimes an indication of the dose being too high can be almost like a return to low T symptoms psychologically. You can feel more irritable, on edge, poor sleep, those factors. Something I certainly do see from time, like you said, not common, but from time to time.
I have to, and it like you said, it's highly variable. So clearly, I think that there are genetic components to that. Not to mention, you have to look at other cofactors. Obviously, sleep, alcohol, drug issues. Are they using other agents in addition to testosterone? All of that comes into the mix. But it's been, I've seen guys, bodybuilders, that take a gram of testosterone a week and are just as cool as a cucumber, so to speak, and just have no mood instability whatsoever. I've had a very small number of patients that if they get just even a little bit super physiologic, they get a bit edgy. And the sleep has been the one thing. I think the more common complaint is sleep disturbance from it. And they're just, for whatever reason, they are just particularly sensitive to that. But other guys don't. It's very interesting. So that, again, this is an individualized medical specialty. There's no question about it.
I certainly think roid rage is not something you'd see on TRT. You know, that's
a myth.
that's a misconception.
It's a myth.
Yeah,
It's a myth. Yeah, it's a myth. Yeah.
Any other things that you come across psychologically speaking from a potential side effect point of view? I think probably psychological is probably not the most common area of side effects I would tend to see on a regular basis. Yeah.
No, not at all. It's again, I like it personally when patients involve their spouses in this decision because it does change the dynamic. So I wouldn't necessarily call it a side effect per se, but if you have one partner who is all of a sudden feeling really good and much better and making all the necessary changes in lifestyle, their libido has now quadrupled. That changes the dynamic in a couple where perhaps the female partner is not feeling that well, is just kind of remaining at baseline, and especially if she's in the perimenopausal time period, also not on HRT, not doing the lifestyle things. I have seen it quite frankly break up marriages sometimes. So it's not a side effect per se, but it changes the relationship dynamic a little bit, and you'll see that too in outside of TRT per se, where one person is committed to making a major lifestyle change and the other one perhaps is not. It can cause some tension. So it's just something to be aware of. I just have seen it enough times over the years that I can kind of pick up on it sometimes. So I encourage guys that, especially people who are in long-term relationships, get your partner involved in this decision early on, because it can make things a little bit rocky sometimes. Most of the time, it's a net positive. I mean, you and I both know that, but every now and then it can cause some problems. So.
Yeah, I think particularly if there's a mismatch, like you said, between sort of either lifestyle changes you're making, or like you said, if the libidos have both been kind of,
that's a big one.
Yeah, if the libido suddenly goes up here and your partner's here, then that can create some degree of friction, can't it? And again,
it's sure.
Sound like therapists, but open communication is often key to that, really. Yeah.
Right. Yeah, exactly. It's just you have to talk. You have to be able to communicate well. So, but yeah, I think that's it for psychological. It's just that's pretty low on the list of issues, I think, especially when TRT is done properly.
Yeah. Probably the biggest group would be physical side effects, do you think, in terms of TRT and physical side effects? Maybe again, a little bit like the psychological, there's the early things that we expect to maybe see in some guys, not always, obviously, and then there's the longer term ones that, often the initial physical side effects, let's say, will reduce and then go away as the body adjusts. And then there might be some longer term ones to expect. So, I mean, what do you think, physically speaking, common ones that you're coming across on semi-regular basis, maybe?
Sure. Well, quite early on, obviously, you can start seeing some of the changes in the skin with sebaceous gland, oil production and things like that. Again, in men who are genetically susceptible to that sort of thing. It's certainly not universal. I think Stephen has talked about that. Stephen Devos, being a dermatologist, he's obviously very tuned into that. And those things are manageable. I talk to patients about them on day one. If you can expect some perhaps transient acne flare-ups, that sort of thing, just a little bit of oilier skin, it's very easy to manage that. And you can jump on it fairly early. And if it becomes a major problem, then obviously you can elevate the treatment accordingly, all the way up to and including things like Accutane, if need be, in a dermatology referral. But very rare. Quite frankly, the most common times I see people with like more serious skin eruptions is when they're adding in other agents, especially HCG.
Yeah, you've mentioned
the testosterone. Yeah. Well, one of the worst cases of cystic acne I've ever seen was in a young man who had been stable on TRT, but then started himself on HCG and ended up with like a really severe scarring acne on his back and shoulders, a little bit on his face, and it was clearly an HCG related phenomenon with all of the there's fluctuations in multiple hormones, obviously, when you introduce an unnatural agent like HCG. HCG is not natural to the male body. despite what people say, being present in microscopic amounts. It's not something that you and I are used to seeing.
Mm-hmm.
And so, yeah, it can cause some issues in that area. Again, usually pretty minor. I mean, even at my age, I'm almost 51. I mean, I still get the occasional pimple every now and then. And I think it's probably genetic. I did have pretty severe acne as a teenager. So there was some sort of a genetic predisposition there. So I think if you've had clear skin your whole life, the probability of you having a major acne issue is pretty low. It's pretty low. Yeah.
And even if you've had like a little bit of acne in your teenage years, when you go on TRT, you might get a little bit of a sort of a few pimples here and there, but you wouldn't expect a huge prolonged outbreak. I'm a little bit like you in the sense that I get the occasional pimple, particularly on my back. I probably should shower more regularly after the gym and things. I'm a little bit of a sucker for just getting straight into work and then showering later that day. So there's certain practical elements. I've looked at, I purchased Stephen Devos's acne ebook, and I think that's quite useful.
I haven't looked at it, but I would be I should do that. I should do that because he's a board certified dermatologist. He's obviously an expert in that area. And you and I as GPs, I think, are well equipped to handle probably 90% of the typical sort of acne flare-ups that our patients will experience. But there are some hard to treat cases, and that's where we have to phone a friend and get his input.
Yeah, it's quite a nifty ebook because it goes through practical advice and then supplements, even sort of naturally occurring antioxidants, that sort of thing. But then discusses potentially the indications for, like you said, about Roaccutane and those sorts of more medically prescribed treatments. So it's quite useful. I've signposted a couple of guys to it, and it seems to have helped, to be fair. I suppose the other adjunct to add into that for acne is, again, looking at the protocol. Is there any relevance to maybe splitting the dose up a little bit more if you think there's a peak and trough, particularly if they're not injecting if it's once a week, you might split that dose a little bit there as well. Yeah.
I think just across the board, generally speaking, smaller, more frequent injections it's one of the ways to get around, maybe not all, but a large number of these potential side effects that we'll talk about. The first line of addressing that is oftentimes just dose and frequency changes. Is stopping those big hormonal ups and downs. It goes a long way. And we'll touch on hematocrit. We'll touch on other areas, but that's typically the reason why in an ideal world, the daily micro injections is probably the best way to get around some of these problems. It just logistically can be difficult for people, day in and day out, year after year, to keep up with that. Compliance is an issue.
Yeah. I was going to say that. I mean, most side effects in this sort of realm. Next one might be fluid balance, for example, a little bit of fluid retention.
Oh yeah, absolutely.
Often one of the mainstays is split the dose up. It just seems to be an answer to a lot of queries. Often the admin team will message me about X, Y, or Z from a patient, and I'll get back in touch with them, and it'll be like, split your dose up a little bit more. And often that's just one of the easiest cures.
It's almost it's my go-to for most of these sort of initial, especially transient problems. And it tends to work pretty well. So should we touch on the cardiovascular fluid stuff then maybe next, since we brought it up? That absolutely. One is fairly common, right? Like that the fluid retention issue is something that I see quite a bit. And I think, there is a phenotype, a certain type of patient that I can almost predict is going to be more likely to suffer from this than others. And it's, quite frankly, it's the middle-aged obese guy with probably underlying sleep apnea, a little bit of metabolic syndrome, a little bit of insulin resistance, that's sort of maybe not full-blown type 2. And then they get put on perhaps a slightly higher dose of testosterone right out of the gate that they probably should not have been put on. Maybe a little bit more conservative dosing would have been better. And then, you get the phone call 2 weeks later that, I'm up, 5 kilos. And, they'll send, I get the pictures of the ankles with the sock dent, after they've been in their socks or their shoes all day long. So Yeah, that's a pretty common one. I'm sure you see it. How do you like to manage that? I think we do it the same way, but be
Yeah,
curious.
I mean, as long as you think the dosing regime is somewhere appropriate, like we don't need to split the dose up any more often, but exercise, keep hydrated, eat a healthy diet, and aim to lose some weight, but give it time as well. And then maybe
Yeah,
potentially, like you said, about if you're going down the medication route, which is often not necessary, to be honest, but you might look at some sort of ARB or you know, like a
yeah,
telmisartan,
exactly.
something along those lines. Certainly would
Mhm.
not use it as indication to use anything like an AI or anything like that sadly commonly gets used. But
Mhm. The AI tends to be the go-to.
yeah,
You hear about it, and there's a mechanism there. I mean, part of the reason this whole thing happens is there's activation of the renin-angiotensin system, of course, but also apparently they've found that there's a change in the sensitivity to estradiol in terms of the antidiuretic hormone,
yeah,
that set point is lowered, and so you'll get a little bit of an increase in estradiol. Antidiuretic hormone comes into the picture, which the name says it all for the
mm,
listeners. Antidiuretic, right? So it causes you to hold on to free water. It works in the kidney, and so but you do have to understand that that's a transient phenomenon, and that set point will recalibrate. So many times, if it's just mild to moderate fluid retention, I know you do the same thing. You just reassure them it's going to get better, and almost always it does. And when it doesn't, sometimes an ACE inhibitor or an ARB, which quite frankly, many of these guys generally need anyway, is it's rare for them. Again, that phenotype I described, rarely do they have optimal blood pressure. And if they're diabetic or pre-diabetic, many times they would benefit from that anyway in terms of kidney and cardiac protection. So that's a very effective way to treat this. Sleep apnea is a big one. I mean, that's if you look at the algorithm for working up lower extremity edema. I mean, sleep studies and a sleep study is part of that workup. So that's a lot of times that's in the mix too. And maybe this will not go away completely until they get compliant with their CPAP and do that sort of thing. But I mean, I think I can count on one hand the number of times I've had to give somebody a loop diuretic, for example, like some Lasix for a few days to dump some of the water. It
mhm,
just doesn't happen very often. So so
yeah,
I've done this long enough that I can make some predictions about who's going to have major fluid issues. And obviously the easy ones are obviously if he's got a history of heart failure, then and those guys do benefit from TRT actually immensely. You just have to be very cautious with the dosing
mhm,
because you don't want to tip them over. You don't want to make them volume overloaded and then have them end up coming to see me in my other capacity in the emergency room to have the fluid, taken off.
yeah, yeah.
Um,
I mean, often beyond, so probably more common finding that we'll see is that they'll complain just that the scale goes up a little bit, which
it
is just
does.
that,
Yeah.
yeah, a little bit more fluid retention,
Hmm.
which often is transient. And my advice often, like you said, is give it time, do all the
Hmm.
right things health wise, and if you are considering some sort of medication adjunct, give something which is going to extend or improve life rather than
Exactly.
potentially be a negative, like an AI.
Exactly.
Yeah, yeah,
Exactly. Yeah.
yeah,
Exactly.
yeah.
Yep. It's usually a very simple issue, and again, it's transient. And if it persists, then you need to chase that down. I think as a clinician, and because maybe there's something else going on.
Yeah,
But yeah, typically that's just not a big deal. Not a
yeah.
big deal. So,
And like most or all the guys we see, it's in that phenotype you're describing. It's all about lifestyle changes as well.
absolutely.
You can't expect the TRT to fix everything. You need to
No. No.
get leaner, gain some muscle, get healthy overall. Look at the
It all
nutrition.
comes down to body fat.
Yeah.
I feel like a broken record sometimes, but I mean that is the key to solving so many of people's chronic medical issues is visceral body fat reduction. It's
Hmm.
just
Hmm.
you cannot get around it.
No.
So sorry.
Reduce that baseline inflammation alongside it as well. I think that's
Absolutely.
like a
Hmm.
driving factor in a lot of these side effects and chronic diseases is inflammation. Is that we learn more and more
Absolutely.
of that over time. Yeah,
Yeah, absolutely. And visceral body fat, there's nothing more inflammatory than having a huge amount of fatty liver, pericardial fat, all that. I mean, it's just so metabolically unhealthy to have that. And it drives all this, it drives hypertension, it drives insulin resistance, it drives hypercoagulability, and puts you at risk for stroke. And anyway, we don't want to go too far. That's a different podcast, but we're in complete agreement on that. It's very lean guys, in my experience, don't tend to have this issue. I mean, I've seen it every now and then, but if you're coming in with, say, 14-15% body fat, the odds of you having a major fluid retention issue out of the gate it's much lower. It's just much lower. I just don't see it very often at all. So, I don't know if that's been your experience, but that's what I've seen.
100%. I think, and I've heard Dave Lee say this before as well. If you line up your guys in terms of their potential for side effects, or the reporting of side effects when you start treatment, often it goes from heaviest to leanest, with the leanest reporting the least issues on treatment. I think that does
precisely true.
Commonly something we see in general.
In general practice, absolutely.
Yeah. And probably we'll touch upon, in terms of physical side effects, similarly to fluid retention, it's not uncommon at the beginning to get a little bit of nipple sensitivity or
sure, that goes along with it.
Exactly. Very similar management, I would say, as well. And kind of to reassure guys out there, changes in nipple sensation is not pre-gyno, or doesn't mean you're going to get gyno, which is a very different thing.
Mm-hmm. And that's a whole nother a really important area, really important for guys to understand. And most men, and it's understandable, they equate estradiol with gynecomastia, but we know it's a bit more complicated than that, isn't it? There's obviously the interplay of, there's progesterone, there's IGF-1, there is estradiol does play a role, but the answer to a little bit of nipple sensitivity is not being put on an AI for the rest of your life, which I can't tell you how many times I've seen that. I've had guys come to me, they're on a milligram of, and now this typical, a milligram of anastrozole either once or twice a week. So why did you get put on this? Oh, I got nipple sensitivity 2 weeks into treatment. I'm like, well, that was 5 years ago. Why are you still on this? And we just didn't want it to come back, so we just stayed on it. And that's absurd, in my opinion, and it's not good medicine. But it happens all the time. All the time. So
when they say that to me, I just be like, well, so did I. I'm not on one.
Right, precisely. It goes away. And I understand. I don't want to downplay the fear. I mean, I get it. That's the last thing you want. But it's just, you have to trust the process a little bit. And you have to trust your provider. When they tell you everything's going to be okay, things are probably going to be okay.
Yeah. Should we touch upon the hematocrit thing then? I suppose that kind of is physical area, I guess.
It's definitely a physical thing. Yeah, for sure. This is a big one. This is a big one, and it's a bit of a pet peeve of mine, only because I've had so many guys come to me feeling terrible after oftentimes a year or more of regular phlebotomy, regular blood donation that was done either on their own in some cases, but usually from, at the direction of their clinician who was prescribing them testosterone. So I think it's fair to say here in the States, I can't speak for the UK, but many of the clinics here have an arbitrary cutoff in terms of hematocrit of about 50%. That seems to be about the average. Now, the Endocrine Society, the AUA here, American Urological Association, in their guidelines, they mention a hematocrit level of 54% as an indication to either stop therapy or perhaps, go donate blood. It's really important to say those guidelines, or that recommendation, is not that's based off of expert opinion, and it is not based on any sort of high quality medical studies, any kind of data. It's just a group of experts, quote experts, that got together and they said, well, shit, we have to decide on a number. What should it be, guys? And they basically, over a few drinks, probably decided that just 54% seems reasonable. Let's just do it off of that. And so it's not an evidence-based recommendation, first of all, and that's in the official guidelines. So taking it down to 50% is even less evident. It's already not evidence-based. Dropping it down to 50% is completely arbitrary. A hematocrit of 50% is normal.
Yeah.
If you go around the world, a hematocrit of 50% is within the normal reference range. So, but the clinics here in town, that's what they do. And so inevitably, when a man is put on, especially on injectable testosterone, as we all know, that has the highest rate of erythrocytosis. It's sometimes referred to as polycythemia, but the most accurate way to describe it is it's a secondary, or the erythrocytosis, meaning it's secondary to something else that's going on in the body. So, and a good example of a secondary erythrocytosis is if you go and live at high altitude, go to Colorado, for example, and you live there for a long period of time, the lower partial pressure of oxygen in the atmosphere causes your body to create more red blood cells. That's it's an adaptation. The same exact thing happens with testosterone. Is many studies show you get a rise in EPO, although not all of them show that, but you get a rise in erythropoietin, which drives that. You get a drop in something called hepcidin, which is sort of the gateway protein in terms of iron. So it drives erythrocytosis, and that's what happens. Is you'll see the hematocrit go up in at least 60% of men, give or take, depending on the ester. And but the injectable testosterone is by far the more. That's usually the culprit. You can get, obviously you get erythrocytosis with all delivery methods, but it seems to be the highest with injectable. I'm sure that's what you've seen too. So this is a big problem because the fear that patients have and the fear that clinicians have that perhaps are not as well read on this stuff is that a hematocrit above 50% puts you at significant risk for DVT, deep venous thrombosis, for clotting basically. So clots in your arms or legs, clots that travel to your lungs, which can be fatal, strokes, which oftentimes strokes are clots that have traveled up into the brain, that sort of thing, or myocardial infarction, you get plaque rupture, and obviously if your blood is sort of thick and hypercoagulable, then you end up with a heart attack. So the data is just not there. The data is not there. Now, I will say, obviously, the final nail has not been put in that coffin. There probably is an upper limit of hematocrit where we need to be like, this is a problem. But what I tell guys is the long-term solution to this issue, if it is a problem for you, and there are some men that are symptomatic. So I do want to make sure that we touch on that. A lot of men run around with elevated hematocrits and have no symptoms and feel great. I'm one of them. I have my hematocrit's usually about 54, 55%, depending on hydration, because it is a dilutional measurement. So if you are dehydrated, I got norovirus not that long ago and got very dehydrated, and I checked my hematocrit just for giggles, and it was about 58. So other than feeling terrible from norovirus, I was fine. I felt fine. And then when I rechecked it, it went down to 54 again. So there's a hydrational component to that. But some men do become symptomatic when their hematocrit reaches a certain threshold, and that threshold can vary. Facial flushing, perhaps some chest tightness. You can get a bit of a rise in blood pressure as hematocrit starts to get really high. So, if those men want to go donate blood once to help relieve those symptoms, I don't have an issue with that. But that needs to be followed up with a protocol change. And this is where these clinics fail, is the long-term management of this condition involves staying on the same protocol that caused it in the first place, and we'll just have you donate blood every two months. And there's an inevitable result to that will happen to every man sooner or later, and that's that they become profoundly iron deficient. They crash their ferritin, and they feel terrible. And it's a feeling like, hey, this testosterone isn't working anymore. I feel just as bad as I did pre-TRT. It has nothing to do with the testosterone. It's the fact that you're now profoundly iron deficient. And digging yourself into that kind of a hole, I mean, I see guys with single-digit ferritins. It can take a long time to dig yourself out of that hole, especially with just kind of conventional treatment, which is usually just oral iron once a day or every other day. Like you and I were trained to treat iron deficiency anemia. This is a slightly different condition because these men are not anemic. They're iron deficient, but without anemia. And that's why it gets missed, I think. I've seen it missed by other clinicians where They didn't even entertain the possibility that this person could be iron deficient, because you and I were trained, and I understand we're trained, iron deficiency equals anemia, and it doesn't. It doesn't. There's a large percentage of and not just with men on TRT, but you'll see this in young women too, who have menorrhagia or have regular heavy periods, and they lose a lot of iron that way. For a long period of time, they won't be anemic, but they will still be like significantly iron deficient. So you have to know how to read a CBC. You have to know how to look at things like the RDW and the MCV and things like that we all like ignore, to kind of clue you in that maybe there's something else going on. So it's anyway, I've rambled a little bit about this, but this is a big one, and it drives me kind of crazy that that we're just phlebotomizing all these men, and we're these men are on such a health promoting, life changing therapy, and they're failing it. They're getting worse in some cases because of what their doctors are doing to them. And not only that, but they're also like provoking major anxiety, because guys will be in a panic when they get that call from the clinic. You need to donate immediately because, well, why? Well, your hematocrit's 51%. That's absurd. It's just not based on any sort of evidence whatsoever. So it's
we tend to sit. I think our guidelines over here are around the 54 mark. So that 50% mark is absolutely crazy. But like you said, I think it's important for people to understand that it's based on, probably it's fair to say, a misassumption that a raised hematocrit by itself increases your risk of a blood clot. And that is, and I think you've done a video on this before where hematocrit doesn't come into the clotting cascade. It's not part of the way.
There.
Yeah. It's not part of the way we develop clots. And I think I seem to remember people commenting the fact that the misconception or the misassociation between high hematocrit equals higher blood clot risk is from polycythemia vera.
It's from hematological malignancy, cancer, which is a hypercoagulable state in and of itself. Yeah. Related to platelet dysfunction. Absolutely.
Yeah. So it's not. It's comparing apples to oranges. Basically, it's not the same situation.
It's not the same thing.
Yeah.
And to be fair, there are some studies, mainly in the lab, showing that perhaps you'll get more platelet aggregation, you'll get more activation of platelets when you start getting into these extremely high hematocrits. But what nobody has been able to show consistently is that, especially with men on testosterone therapy that have erythrocytosis, that we see higher rates of clots, higher rates of stroke, higher rates of MI, that sort of stuff. So your hematocrit may be elevated, but where's the pathology there? Where's the higher risk of stroke? Where's the higher risk of DVT, pulmonary embolism, et cetera? There may be a signal there. Maybe we just, we haven't found it yet. But the fact that it's been so difficult to find suggests that even if there is an effect, it's going to be very small. It's going to be very small. And it's certainly not worth phlebotomizing everybody that goes over 50%, and precipitating all this anxiety and stress over something like this. That's my opinion on it. We were talking just before this, before we started recording, about there was a paper that just came out in June where they looked at gold miners in La Rinconada, Peru, which is the highest city in the world, and there's about 50,000 people that live there chronically. And they were studying all the coagulation patterns and all the coagulation studies, or coagulation parameters, I should say, of a large number of these men who are generally like young, healthy, between like 30 and 50, and doing something called thromboelastograms on them. And these thromboelastograms, which, if you remember back in your residency days, you probably don't do a lot of TEGs anymore, but I don't either. But in the ICU, it's a really useful global test of blood clotting. They looked at some of these men, and some of these men, like their average hematocrit, if I recall, I'm going to do a video on this, but average hematocrit was somewhere close to 70%. They did not have abnormal thromboelastograms. In fact, they seemed to be a little bit less likely to coagulate. The clots that they made were less strong, less durable than the control group. So even at these extremes of hematocrit, like well into the high 60% range, at least in this particular study, they were not showing that their blood it certainly was thicker, obviously, with a hematocrit of 70%. The viscosity was higher, but it was not it could not be objectively shown to be more clot prone, even at a hematocrit of approaching 70%. So very interesting study. I'll eventually put out a video on it when I get a little bit more time. But this is not a slam dunk. You have to donate at 50%, and even at 54%. I think if you when you pin down the endocrinologists that came up with this, they and I've seen videos on this. They admit that this is a bit of an arbitrary cutoff. We had to pick something, and so they made an educated guess, and that's okay. I get it. For guidelines, you have to do that. So you have to pick a number, and so 54% seemed reasonable based on the information that they had, but that doesn't always mean it translates into reality.
Yeah, well, guidelines aren't perfect.
No, they're guidelines, right? That's what they're for. They're guidelines.
Yeah. I've spoken to a hematologist before about it, and he said, "Why would you? Why would you worry about hematocrit?"
Well, there you go.
Yeah, it's because
exactly. So somebody who's an expert,
blood docs. Yeah,
like that's what they do every single day. You can probably trust what they have to say in that regard. So.
Yeah. Do you ever see patients with high iron levels on TRT? They're not giving. Blood. Hepcidin suppression, so they can
all the time
build up a little bit of iron. Yeah.
Well, they have many of them. I pick up a couple cases of hemochromatosis per year, every year. When I see guys initially, whether they're already on TRT or not, I mean, I get an iron panel and a ferritin on most of them, and what I have found a number of, hemochromatosis is it's a heterogeneous condition, and it has it's a genetic condition with what they call variable penetrance, which means you may have the gene for it, but that doesn't mean that you necessarily have iron overload. Whereas someone who has the same gene pattern, they actually might have iron overload. So it gets highly variable. So what I've seen lately, in fact, I can think of two cases recently. I picked up guys on their iron panel. They will have a high iron index or transferrin saturation. So they'll have, you divide iron over TIBC, it's, above 49, 50%. That's suspicious of hemochromatosis, and they may or may not have an elevated ferritin. I would send them off for genetic testing, and they come back with one or more. Usually they're heterozygotes, so they've got one copy of, but sometimes depending on the variant, there's something called an H63D variant, which even the homozygous folks that have that, I picked that up a couple times, even the homozygotes, so they'll have a high iron index, but they won't have high ferritins, and so they rarely need to have phlebotomy. They just need to be monitored. But then I have picked up a couple people with ferritins of 800, 1200, and they have classic hemochromatosis. So one of my very first TRT patients ever as a family medicine resident, I was like 28 years old, was an elderly guy that came to me, and he had abnormal liver function tests, and he looked a bit ruddy, I should say, in the face. And anyway, in the course of chasing down his abnormal liver enzymes, long story short, I discovered that he had serious iron overload issues. He was hypogonadal as well, so treated his hypogonadism and then referred him to a hepatologist, and ultimately, he was on a regular course of phlebotomy. So that's a case where yes, phlebotomy is absolutely indicated. It's a good idea if you have high ferritins. A lot of times, if they're over 1,000, that's an indication for phlebotomy. Although some hematologists will phlebotomize when they're lower than that. But that's I pick up hemochromatosis in people of Northern European ancestry is not uncommon. Something like 1 in 200, and maybe even higher in certain areas. So it's a thing.
Yeah. And that's the thing, I suppose, to the opposite end of not overly concerning ourselves with hematocrit and not routinely blood donating but make sure you're maybe keeping an eye on your ferritin levels to pick something up an iron overload is not good for your health, because essentially excess iron.
Iron is toxic. Iron is a pro-oxidant. It's absolutely toxic. It's iron overdoses are on my emergency medicine boards all the time. There's always a case of a child that got into their parents' iron tablets, and then they need deferoxamine and that sort of thing. So yeah, iron is absolutely toxic, and there's some debate about what the optimal ferritin level is in men and women, and we can go into that at some point in the future, but it's something that I do keep an eye on. So
Yeah.
it's important to say it is an acute phase reactant. So what I mean by that is if you have an acute illness, a good example was like during COVID. I mean, all these people that were really sick with COVID had ferritins that were through the roof. People that have chronic inflammation, chronic kidney disease, like dialysis patients, always have high ferritins. Sometimes people with really bad heart failure will have high ferritins. And so you can't typically, like in you and I, we can go off the ferritin to diagnose iron deficiency, but the threshold is different in dialysis patients and other people that have these kind of chronic conditions, because the ferritin will be abnormally high. And it's not because in fact, many times they're iron deficient. So they still benefit from iron, but their ferritin will be above 100, or say above 200. So it can fool you sometimes.
Yeah, it's not a foolproof test. You've got to think about the background of the patient. I always say that to guys, that particularly inflammation is going to drive that ferritin up often. So it's not so reliable in those circumstances.
Yeah, you got to look at the TSAT, transferrin saturation as well.
Yeah,
kind of look at the whole picture as well.
Yeah. Any other physical side effects you can think of that are maybe common, or things to mention? We won't touch upon estradiol maybe, because that's a whole video. We've done that one before.
Yeah. I've heard it can have some effects on your hairline. I don't know. Nah, it's a myth. Yeah, that's a myth.
Thick as a rug.
Yeah.
This is.
Yeah. I have to have that talk with guys. It is if you have the gene or genes, because there are multiple genes for androgenic alopecia. It's not surprising if that if hair loss is accelerated when you start TRT. So, and for some guys, that's a no-go. That's a reason not to go on therapy, and I understand that, and that's okay. But it will accelerate hair loss in many cases. But again, if you don't have the gene, I mean, I have a good friend of mine who's in his mid 60s and takes super physiologic amounts of testosterone, got a full head of hair.
Nice.
Yeah. Very jealous.
Yeah. So I say the same thing to guys. If you've got a genetic propensity to lose your hair, TRT will very likely speed it up. So
it will.
Yeah.
And then, and that's where we get into the discussion about finasteride and all those, these other adjuncts, which I'm obviously leery of those, but many men do use it successfully. It's just not something I'm a huge fan. I'm just not a fan of, as you know, blocking hormones in general, if it can be helped. So, but that's a big one, and I get it. Like if you're a young guy and you're in your 20s and you're in the dating market, thinning hair can be psychologically pretty devastating. So, when you get to be my age, you don't care as much. But there was a time when I cared a lot. So.
Yeah, absolutely. I mean, when you've been married for a good while, maybe it might be a different situation if you're on the dating market and you're a
absolutely
young bachelor and things. Yeah, but there's a lot of
we can let ourselves go. It doesn't matter.
Yeah, exactly. We've done our bit. Yeah.
That's right.
Yeah. What about, I suppose, going down to sexual testicular atrophy? So shrinking of the testicles.
That's a thing. That's a thing.
Yeah. Without HCG, the chances are that you'll at least get some degree of shrinkage. But the funny thing about this, Andrew, I don't know if you find this, is that guys, the variation in the degree of shrinkage can be quite dramatic. Some men,
absolutely.
I've honestly had patients who say, I haven't noticed any shrinkage whatsoever, and they've been on it for 2-3 years. On the other end, someone can come back after a few months and they can say their testicles are like little tiny olives.
Exactly.
So it's quite funny the way there is that dramatic variation, but certainly I will warn guys, at least some degree is very likely. And obviously, like we said about the fertility thing, and it's just because we're no longer getting signaling down from the brain to the testicles, so they're basically dormant.
Yep.
Common one.
Yep. That's just the way it goes. Yeah.
Yep.
That's part and parcel of the treatment, unfortunately. And even you mentioned HCG. Even HCG, it certainly can help in many cases, but it's still going to happen in my experience. It's not like it's you can completely blunt that effect with HCG, and so ultimately it is primarily a cosmetic issue. And so if it's bothersome to you, then you just have to you can take HCG obviously, or don't get on therapy. But you're right, it is variable. It's highly variable. So it's in my experience, it's been less of an issue with my guys mainly because they just feel so good that they don't care. They don't care.
Yeah.
And again, and many of them too, like they've been in long-term relationships. They've already had their children. It's not something that they put a lot of weight into. And their partners don't care, despite what guys might think. The women don't care.
Yeah,
they don't care.
It's like Ali Gilbert says, there aren't any ladies who call themselves bull girls or bull.
Right.
There's not many women out there on Tinder saying I'm after large testicles. So yeah, I think
probably not. I'm not on Tinder, so I don't know, but you're probably right.
Yeah. But like you said, if it does bother you, you can try HCG. HCG is not perfect in for a lot of guys, and it may work can work pretty damn well in terms of testicular atrophy, but it's not 100% perfect like you get sold. And again, not all men tolerate HCG very well, so it might be something to discuss with the provider. But yeah, at least some degree of shrinkage is highly likely. Yeah,
it's highly likely. Yeah, absolutely. Yeah, that's oh, go ahead.
Yeah, I was just going to say, what's your view in terms of those older guys? How often are those chaps wanting to try HCG? Because the other thing to some people find HCG adds to their protocol. When you're dealing with the older guys, is it something that they generally do get results positively, or is it a bit hit and miss?
Well, I don't get very many of them asking about it, quite frankly. But one of the things I do tell them, obviously, there is there's diminishing returns as you get older, and that's actually well documented in the literature. The amount of testosterone that you can produce for a given amount of HCG, it declines, especially after the age of 50. But it's not like you can't get, in many cases, some production, even in men in their 60s, and there's data to support that. But you're sort of beating a dead horse. You do have some end organ resistance. Things, nothing responds as well when you're 65 as compared to when you're 25. And it's a rare man at that age group that wants to maintain fertility. Although I have come across a couple over the years, and okay, we'll do the best we can, but don't expect miraculous results from that. But I tend to be, especially an older man, especially if they're a little bit medically fragile, or they're on a lot of other medications and things like that. I try to keep things as simple as possible. Bioidentical testosterone therapy is what these men need. That's what makes them feel better. That's what improves their health. That's what has the least amount of side effects. And again, you start adding in this unnatural agent into the mix, especially in somebody who's elderly. It can be, you can ask for trouble sometimes when that happens.
Yeah.
So it's very rare. Like I have no men in that age group currently in my panel that are on HCG. It just doesn't work. It just doesn't. And again, that's not the group that is interested in the potential benefits of HCG. Like we talked about, fertility and atrophy is just not on the table for them at that age. So again, I keep things simple with those men.
I think as you go along in this business for longer, you do realize the best is often just to keep it simple, straightforward. Use testosterone, good lifestyle.
Less is more. Less is more.
100%.
There's definitely, in this whole like biohacking community, and I hate the term I don't like biohacking, but we're stuck with the term. There's this tendency to want to tinker and to use your, as a clinician, use your patients as a science experiment, or as guinea pigs, or use yourself and try all these different supplements and protocols and tweaking this hormone and that hormone, and then getting blood work and seeing what the difference is. And at the end of the day, I think it doesn't necessarily move the needle very much at all. It can be really expensive, and oftentimes it can be harmful. So as I've gotten older, I've just become perhaps a bit more curmudgeonly and conservative, but the simple things work the best. Bioidentical hormone replacement for both men and women at reasonable doses, combined with massive emphasis on nutritional and lifestyle interventions. That's the secret sauce. And then all these other adjuncts are all great. We can talk about them and introduce them perhaps one at a time. But many men, they just focus on, they put 90% of their efforts into getting 5% of the results from these, little biohacking tweaks that are sometimes really expensive, and they want to get on growth hormone and, all these other different agents. And really what they need to be doing is being consistent in the gym. And I see that all the time. They're all focused on the biohacking. And when I ask them about their workouts, well, I've been really busy. I haven't made it to the gym in 3 weeks. Okay, well, you're not moving the needle. That's where the rubber hits the road, is just the day-to-day consistency and your training, your nutrition, and then bioidentical hormone replacement. And then that's what you need. And everything else is that's the sprinkles on the cupcake if you want to go there.
Yeah. An important thing to add as well, like you're saying, is that the chances are those guys ticking those important boxes, gym, diet, sleep, stress management, they're the ones who we don't tend to see run into the side effect issues, other than the guaranteed ones like the hair loss, atrophy, that's
right,
irrespective of lifestyle. But yeah, they're the ones who are going to get a much smoother journey. They're making the most of the treatment, essentially, is a good way.
Exactly. It's the guys that we've said it 1,000 times, the guys that get the best results from TRT and HRT in general are the guys that put in the work. You have to put in the work. And if you don't know what to do, then that's where you and I are. That's our role, obviously, is to help facilitate that. There's a lot of other experts out there as well who are non-medical providers that can help with nutrition and diet if you don't know where to start. But that's where it is. I mean, the big transformations, the guys that we see that we're so proud of that lose 80 to 100 pounds over the course of a year and radically transform their lives. It's not because they added 2 units of growth hormone at night. Like, that's not what did it, right? It's the lifestyle overhaul that did it, and the mindset that goes with that. So
yeah, it's adding 2 pounds to the bar each week that's done it.
Exactly. Yeah. It's getting up at 5. It's getting up at 5 a.m. when that alarm goes off and you don't want to go to the gym. It's getting up and going to the gym. Yeah. Because that's the secret. That's, you guys are here on this podcast looking for secrets. That's the secret.
Yeah. That's a good place I think that's a good place. Yeah. It's a bit of a disappointing secret, but it isn't, because it's you taking responsibility for how you feel, and that's where you get the results. I think there's so much psychology to this idea of being responsible for how you feel and putting in the effort and getting the reward. And that's what, often correcting a testosterone deficiency often gives you that ability back to get the results that you kind of deserve from the effort you put in. It's a really good way of looking at it. And
that's what we do for our patients. That's the part of that triad of nutrition, exercise, and hormones that you need a good medical provider for. But there are 2 other parts to that triad, and I can't do the workouts for them. You can't come to their house and cook their meals. You know what I mean? Like, they've got to buy into that. And the guys that do, they're the ones that get the results, and the results are phenomenal in some cases. They're life-changing. Guys coming off of all these chronic medications, guys feeling good, improving their lives. They advance in their business, they advance in their relationship, but it's all from putting in work 100%. And changing and learning new habits. And it's hard to learn new habits, but that's what you have to do.
Yeah. I think that's a good place to finish. I think that's been useful.
Sounds good. Yeah. Hopefully.
Yeah. Won't have covered every side effect, but there are, that's probably
there's always going to be There's always going to be weird ones out there that people get, and leave them in the comments, and you and I can we'll try to answer some of those in the comment section if guys have come up with odd side effects. There are there's things like carrier oil reactions and stuff like that we could obviously get into, and other things that sometimes are just unexplained. But yeah, I think we hit some of the major ones.
Yeah. And we could always do follow up if there's lots in the comments as well. Where can people find you? Where can people find you?
Yeah, so I have a YouTube channel just like you do as well. It's at Man Medicine. I have a website. It's manmedicine.com. You can reach out to me there. I have a very small private practice, and I keep it small deliberately so that I can give a lot of attention to my guys. But I currently take patients in Oregon, Utah, Florida, and Texas. I can do consults worldwide. I enjoy those. If you just need some advice, need to be pointed in the right direction, need a second opinion, that sort of thing, or just want to pick my brain on something, I'm available for consults there. I enjoy those kind of visits as well. So
brilliant. Thanks for joining us, Andrew. And
okay. Thanks, Max. We'll do it again. I hope so. Perfect. All right. Talk to you later.